Hey, good morning. This is Bill Lee. Um, just going through a common EMS strips lecture. This was developed by Tom Charlton, who's kind of our regional EMS director, and anyway, is a great resource in general. Disclosures from him, there are none. Disclosures from me, there are really none. I work here between a couple of different Mercy sites, and I'm the director at Anderson and Rookwood. So I'm sure that I will see you guys at one of those two places at some point. All right, we'll get started here. Objectives today, just to review some of the common EMS strips and then some safe medication administration practices as well. Certainly open to quite a few questions along the way, and we can kind of talk through this. I am by no means an authority on all these drips, but we use them daily, and so if there's a discrepancy or you hear something that sounds weird, we can talk about it and kind of go from there. So as far as sedation goes, we're going to talk about ketamine, propofol, Versed, Ativan, fentanyl, and then Precedex, which I don't know, do you guys use that very often? You probably don't see it very often unless you're transporting like a MICU crew or something.
Yeah, we've as far as that one goes, I haven't really seen it. The other ones, obviously, yes, but yeah, I don't know much about that one at all.
Yeah. All right, so we'll talk about that. All right, so ketamine is one of my favorite medications. The reality is, I don't think we probably use it enough because it kind of makes people feel a little bit weird. So it's a sedative, hypnotic, and analgesic. The thing that gets a lot of people is this hypnosis, essentially, and so it is a medication that is hugely beneficial, especially with like awake intubations, for example. And so the biggest time that we would use this typically is somebody that is like maxed out asthmatic, where we are essentially trying to keep them breathing and keep their own respiratory efforts intact while we do kind of an awake intubation. Other times that we use it, we use it a fair amount for like fracture reductions and things of that sort. And actually in kids, we use it a ton for like sutures. And so, normally when you give this medication, the onset varies depending on whether or not it's IV or IM. IM takes significantly longer to take effect. And longer to essentially offboard because you're typically given a bigger dose. And then the IV dosing actually takes effect within a few minutes and essentially is off and typically I think around 45 minutes to an hour or so. Typical dose for loading for the first dose is 1 to 5 milligrams per kilo. IV, and then it's followed by essentially a 0.75 or 1 mg per kg per hour. Normally on this medication, my starting dose is, essentially 2 milligrams per kg. We use it more again for peds. So if I'm doing IV, I do 2 mgs per kg, and then 4 mgs per kg if it's IM. You can titrate it over time. This is not typically a medication that I do a lot of titration on. For us, it normally is just a typical loading dose and then kind of riding the tide essentially until we can transition them onto a different medication or sedate them otherwise.
So
go ahead.
Sorry. So is my understanding with ketamine, if we're kind of coming out of it, that benzos can be used to kind of lessen that effect? Is that something that's true? Is that
what can be used to lessen the effect?
Like when they're coming out of that sedation, that if we did give a dissociative dose of it, that if you use a benzo coming out of it, just kind of to titrate off of it, is that true? It's just something.
And you can definitely do that. The big thing is kind of what they would call like a reemergence phenomenons, right? So when people are coming out of this, they recognize that they've been in kind of this like hypnotic state, um, or dissociative state for a little while, and they're starting to put two and two together. And sometimes people are pretty confused when they're coming out of it and can get really agitated. So a touch of Ativan would be fine. Um, you know, my typical practice, especially with pediatric patients, is to make sure that the room is more or less as calm as I can make it. I normally turn the lights down quite a bit. Um, if there's a parent or somebody that they've been kind of clinging to on the way there, I normally put that person at bedside, right at the top of the bed, and that way they can kind of speak calmly to them and hold their hand and stuff kind of coming out of it. That tends to help quite a bit too.
Thank you.
That's ketamine. All right, propofol, another one of a lot of these medications, man. Again, I don't get to use them as much as I would like a lot of times. So propofol is another one of those medications that I absolutely love. When you guys see it, you typically probably are seeing it more for keeping people, essentially sedated when they're ventilated. We use it here quite a bit for, like, again, fracture reduction, or like shoulder reduction, things like that, joint reductions. So we use it probably almost as much for that as what we do for sedation with intubation. And so my favorite thing with this medication is, typically if you're using it more in like a short setting, again, which you guys typically aren't doing, is you can kind of talk to the person as you're putting them under, and talk them through, hey, this is going to feel warm in your arm. And I normally talk to them about whatever their work or wherever they live or something of that sort. And then you can just see them go out, and almost without fail, we do the reduction, and then as this wears off, they wake up and they're like, are you guys going to start? And so, like, people literally think that they just had like a long blink almost, right? Like, and so it's not, as opposed to like Versed and some of the other medications that you use, when people come out of this, they are clear-minded, and oftentimes are ready to go, I mean, almost immediately as soon as they wake up, from their perspective. Clearly we watch them for a little bit longer, but you guys typically are using it more as a drip for sedative, with folks that are intubated. Drip is typically started at 10 to 25 mics per kilo per minute and titrated up to 5 to 10 mics per kilo every 5 minutes until the sedation is achieved. And normally, kind of max dose is somewhere around like 75 to 100 mics per kilo per minute, so a little bit variable. I think most people actually do really well, normally starting off around like 10 to 20 mics per kilo per minute. They do pretty well that way. The big things to watch out for this: it absolutely causes respiratory depression, and it absolutely causes hypotension. The respiratory depression is not that big of a deal, especially if the patient is intubated. If we're doing, again, these short-term sedations where the plan is not to intubate them, it becomes something that we watch very closely. Hypotension is definitely also a possibility, and so we're really careful with this. When we're talking about, especially like intubating septic folks, or sedating septic folks, essentially, you've got to be really careful with this, with those pressures. And so, etomidate can drop the pressure. We normally intubate with like etomidate and rocuronium. Etomidate can definitely drop the pressure as well, but propofol is more prone to do that, especially at higher doses. And then don't use with patients with allergies to egg or soy. So again, just something to be aware of.
So really quick on this one, and you're correct in saying we mainly see this with intubated patients. What would you recommend as far as, if we have a patient that's continually waking up on this, versus, as far as increasing to keep them sedated or bolusing to kind of put them back under, or what are your kind of recommendations with that?
Yeah, typically, from your end, um, you would not be bolusing so much on this medication. So typically, if and even in the emergency department, typically is I'm titrating this medication up. Um, you know, it's pretty much for a bolus of propofol. It's physician. I personally have to push the medication for a bolus. Um, However, you can use this in conjunction with a lot of other medications. If you're having trouble with this medication, you typically can give them a dose of Versed, um, which actually kind of works in conjunction with it really well and will help kind of knock them back down.
Okay, so you would recommend it if we had a patient that was continuing to wake up, go ahead and do the Versed, and obviously we would call for any sort of, adjustment in the medication. But so if they're continually waking up, you say just go ahead and go with Versed then.
Yeah, yeah. And so, because Versed is a lot easier to bolus, and essentially, the big issue with this is kind of that hypotension. And so, if you push too big of a bolus or things of that sort, um, you know, it can be more troublesome than Versed.
Okay, thank you very much.
Speaking of the devil, here we go. So this is another great medication. The beauty of this medication is it sedates and then also has amnestic properties. And so when you're doing a procedure, even if the patient is kind of in that twilight or not completely out, which again, sometimes we prefer to not put them completely out depending on kind of their underlying respiratory status up front. But a lot of like minor procedures will use this medication in conjunction with fentanyl to not just do the procedure, but to also have that amnestic property, right? So the patient is kind of on the verge of waking up throughout or kind of in that twilight. It's actually pretty okay because when it gets to the end, they're not going to remember any of it anyway. And so this is a great medication for those types of procedures. It also has a pretty long half-life, and so it's quite useful that direction. Loading dose typically, again, they're saying 0.5 to 5 milligrams IV, and repeated every 5 to 15 minutes until sedation is reached. I will say from our end, we typically are using like 2 to 5 on this medication, and so that's normally I normally don't start anywhere below 2 if I'm reaching in for this medication. Maintenance dose 20 to 100 mics per kilo per hour. You can titrate up or down by about 25 to 50% as needed. So this is something that you want to be very careful with elderly. One, it causes respiratory depression. Again, more so in your older folks tend to have respiratory issues already. A lot of folks with COPD, et cetera. But it can cause respiratory depression. The other thing is in elderly patients, it causes this like CNS depression. And oftentimes they have a really hard time transitioning off of this medication, if you will. So they get like agitated or confused and things like that when this medication is wearing off. So you do want to be pretty careful with it with your elderly folks, but not to say that we don't use it for that. We certainly still use it with them as well. Thoughts? Good. All right. Ativan. All right. So this is a mild amnestic. Really, you don't get too much out of that. Quite frankly, I don't know that I've seen anybody with much of the amnestic effects of this. It is a benzodiazepine, similar to Versed. Loading dose, they're saying a 0.02 to a 0.06 mgs or milligrams per kilo. In effect, that's going to be typically like a 0.5 up to about 2 milligrams for most people. And so maintenance dose at a 0.01 to 0.1 milligrams per kg per hour. And then they max dose at like 10 mgs or milligrams per hour. Again, causes respiratory depression, and again, hypotension. So with all these medications, oftentimes just keep cycling your blood pressures and keep that pulse ox on, especially if you're seeing any like CNS depression. You definitely can start seeing the respiratory depression as well. This is a great medication as well. Again, if your propofol is starting to max out, or you're thinking like, man, this is not keeping that patient as sedated as what I would like, I would say either Versed or Ativan, or lorazepam would actually be a great medication to kind of just reach for at that point in time.
Perfect. Thank you.
Fentanyl. So you guys typically are using this, with patients with fractures and things like that. You probably don't see it as often as like an IV drip, but oftentimes when you get people with that, like again, femur fracture or like a shoulder dislocation or things like that, it's a great medication to have. There's two reasons for that. One, it can cause hypotension, but it's less likely to cause hypotension than most of your other narcotics. And so, and it has a great onset, and people tend to tolerate it well. It can also cause vomiting, similar to other narcotics. Again, tends to be less in my experience than typically with like what I would see with morphine or other. Loading dose 50 to 250 micrograms. I got to be honest. I typically would start, for your older folks, somewhere in the neighborhood of like a 25 to 50, and then for kind of like your average person that's out and around, that's in pretty extreme pain, probably more of like 50 to 100. I'd be fairly hard pressed to go much more than that with like the initial load or kind of bolus. But anyway, it's listed at 50 to 250 here, but I'd probably tighten that up a little bit. Maintenance dose, typically 25 to 100 micrograms per hour. Oftentimes you'll see it more of like a 1 microgram per kilo per hour, which most people is going to be 70 to 100, which is pretty common. You have this rare complication of this frozen chest syndrome, and so more or less that's almost like a spasm of the chest wall muscles, which can make it really difficult to breathe. So it's something to be aware of. I don't know that I've seen this personally, but certainly that could be the case. It is reversible with Narcan. So if you run it into this place where you thought you bolused them too much, all of a sudden you can use Narcan, and you can reverse them out of that, but know that it will be more difficult to get their pain under control after that. And so always just a little caveat there. Yes, you can reverse it if the respiratory depression is significant, but their pain will be out of control until the Narcan wears off. All right, Precedex. I got to be honest with you, I don't see this medication a whole lot. It's a medication that typically is more ICU driven in most places. You guys will, I'm sure, see it in transport on a drip, but oftentimes they convert people over from propofol onto Precedex in the ICU, but it's not something that I typically see or do a lot of. It's an alpha-2 agonist with sedative and anesthetic properties. Loading dose 1 mic per kilo over 10 minutes, and then maintenance dose of like a 0.2 to 0.7. Here they're saying you can give it to patients that are not intubated, but it requires caution, especially if other sedating medications are used. So, again, oftentimes this is not necessarily the go-to medication for most people. I think that they use a fair amount on like head injuries. I believe they also use it a fair amount with essentially like excited delirium with withdrawals, things like that. And so there's quite a bit of like coexistence in that space for like Ativan or Versed or things of that sort. So just, again, it's a respiratory depressant. Be aware if the patient's not intubated. Paradoxically, it can cause hypertension and hypotension as well, and some bradycardia and nausea. And so you don't get a lot of these medications that they can cause elevated blood pressures and low blood pressures at the same time, but this one certainly can. By the time that you guys are seeing this medication in particular, they probably would have been on it for quite a while. This is not something that you typically would see, you know, not something that most of your emergency departments are going to start, quite frankly. And so most of your patients with this have probably been in the ICU for a while and have been stable on this medication for a while. So it shouldn't be much to do other than, you know, maybe titrate en route. All right, here's a lot of the fun stuff. So we'll go through some of these pressors as well. Check our time real fast. Looks like we're doing okay. You will see a lot of these medications, you know, kind of just going through our list. As far as like epi, norepi, probably see some phenylephrine, some dopamine, maybe a little bit of dobutamine. You may or may not see vasopressin. I have not seen much of that for the last several years, and so we'll talk about it briefly as well today. But you know, you may not use too much of these medications like vasopressin all that often. So you're probably still in the camp. You probably have seen this with, like, you know, ACLS and protocols and things like that more remotely. But have kind of steered from that in recent years.
Yeah.
All right, so this is what it all comes down to, right? So your adrenergic receptors. These are, once you start kind of like looking at these and kind of memorizing which place most of these affect, you'll kind of be ahead of the game, right? And so it takes a little while to like get these and memorize them, and you know, even after you've been away from them for a while, it's always good to come back and look at this chart. And so I'll probably actually flip in between this chart and some of the slides as we move forward. But this is where most of these are coming from. So your alpha ones, essentially, they affect the vascular wall in the heart. So they do vasoconstriction, and then essentially they increase the duration of contraction without increasing the rate of the chronotropy. Okay, and so so that's your alpha ones, right? And we'll kind of talk through these, and once you start hearing what they are, you'll be on track with it. Your betas, or your beta adrenergics, you've got beta 1s and beta 2s. Your beta 1s affect more your heart, and so they increase essentially the squeeze and the pace. Your beta 2s affect the blood vessels, and they cause vasodilation. And then you get dopaminergic receptors. So these tend to cause more effect in like the splanchnic or mesenteric or renal, and then they cause vasodilation. And so we don't get much into the subtype, but subtype could cause vasoconstriction. So most of the time when you're thinking of like dopaminergic receptors, think of essentially vasodilating like the bowels and whatnot. And so without further ado, we'll get started on that. All right, so epinephrine. Epinephrine has a mix, and depending on when and how you use it, it can actually affect two different kind of subsets. And so it can be push dose or as a drip. It stimulates the beta more than the alpha, but some of that is dose dependent. And so at low doses, it affects the beta more. At high doses, it affects the alpha more. Okay, we'll talk about that in a second. So, can bump the heart rate. We've all seen this. Clearly we're giving it in codes and for anaphylaxis as well. You're pretty much always going to see this heart rate bump up. It increases contractility, cardiac output, vasodilation, and bronchodilation. And at higher doses, it can actually cause some vasoconstriction as well. And so things to look at specifically for this, kind of going back, right? So here we are. So it causes a little bit more beta, more than alpha. Epinephrine essentially is, when you think of like fight or flight, like this is the medication, right? Like this is what your body is cranking out already. And so the big thing with this is it increases your heart, how much it's squeezing, and then the rate. Vasodilates most of your blood vessels. And the idea essentially is you're ready to fight, right? It causes some vasoconstriction. That vasoconstriction comes more typically in like your bowels and like the mesenteric, like the inner abdomen, because you don't want to digest during that time, right? Like you want all your blood essentially out into the periphery where you're like using vital organs at that point in time. So the really interesting thing is with this, if you think about how we dose this medication. So when we're dosing subcutaneous for anaphylaxis, we're giving a much smaller dose, subcutaneous or IM, right? And essentially at that point in time, it causes more of this, more of like this beta receptor initiation, which causes bronchodilation. And that's what we're looking for. Like that's the biggest part of this. And you might get some of this like heart effect as well. But the biggest part is you're looking for bronchodilation. As we're using it more like in codes and things of that sort, that's when you're looking at essentially getting some of that heart, like that heart squeeze and rate. But you're also looking for vasoconstriction in most of the periphery. And so that's kind of what you're seeing more with the high dose. And so it tends to squeeze down in the periphery and then also in the like in the bowels or like the splanchnics. And so anyway, kind of vasoconstricts all of that and pushes blood into kind of that central core, if you will. All right, so this is Tom's way to build a push dose epi. So you're going to take epinephrine, 1 milligram per 10 mils. That's our cardiac dosing, right? And essentially you're going to get a 10 cc flush. You're going to pull 1 milliliter out. All right. So essentially, and then you're going to use a stopcock, push that 1 ml of cardiac epi into a flush, and then you're going to agitate. And then essentially at that point in time, you have 10 mics per mil. And then you can do like a 1 to 3 mils every 5 minutes as needed. You guys aren't typically doing the push dose epi, but if you see it, this is where it's coming from. Certainly.
And with this, is it also possible we could put this in like a 100 ml bag? Or
yeah.
Yeah. Okay. And do it more.
This is, I think, the way that you can do it. Yeah. Yeah. So in a pinch, this is how it works, right? And so, so as far as like making an epi drip, you can take essentially 1 milligram again. That's a full vial of the 1-to-1. Inject that into the liter of normal saline, and then you have a 1 mic per mil. And then for bradycardia, you can essentially titrate that to 2 to 10 mics per minute. And if we're doing more, we need like that vasoconstriction. Essentially, we would do like more like a 5 to 15 mics per minute. So, so that's what we're looking if you're doing push dose. Quite frankly, I don't do a ton of push dose. I know several of the docs do, are a little bit more free with it or comfortable with it. It's not something that I train doing, and I tend to not do it a lot. But it is something to have in your back pocket, because there are definitely times when it is super handy to have. And so again, something to be familiar with, and just know that it's there if you need it.
Would you consider this a better option or a worse option as far as using in like a septic patient?
So typically in a septic patient, I would be more prone to use norepi as opposed to epi. But if are you thinking as far as like if they're hypotensive or bradycardic or?
Yeah, more hypotensive. Yeah, hypotensive, is more what I was looking at.
Yeah. So the big thing with epi in particular is this vasoconstriction tends to cause a lot of vasoconstriction at like the renals, and then kind of it would be much more unlikely that you would affect the bowels, in my experience, with like higher dose epinephrine, but you definitely can essentially clamp down those kidneys, and where you're not getting a lot of perfusion. And so I would use this cautiously in septic patients. I would say typically, if you're thinking about epi, then they should already be on a norepi drip. And we'll talk about that in a bit.
Okay, thank you.
Yeah. So norepi would be my go-to typically for sepsis, and epinephrine would be kind of a backup to that, or if you're still having trouble. So norepi or Levophed, again, is a fantastic medication. It is, I would say, even when I trained, it was kind of becoming like the go-to for sepsis and shock, or septic shock at that point. And there's some really good data on why that is. And so, as opposed to using, there was some talk in the past about using like phenylephrine, epi, etc. The beauty of norepi is it has alpha and the beta action, beta 1 more than beta 2. And so it constricts blood vessels, it increases your heart contractility. And so let's go back here a little bit. Okay. So the big thing is it causes this beta 2 vasodilation, but specifically it causes some of that more in like the like more in like the mesenterics and like the renals and stuff as well. So so you're less likely to injure your kidneys, essentially on norepi, as opposed to using an epi drip. So that's a big part of it. All right, so can cause some reflex bradycardia. Typically don't see that. We know about the hypertension. It can cause some peripheral ischemia, right? So this one preferentially vasodilates more of the I guess like the bowels and renals, at the expense of constricting some of the peripheral vasodilation, or vasoconstriction rather. Dose typically is 8 to 12 mics per minute. And then you can, essentially move on from there to go to like 2 to 4 mics per minute for an infusion, and then kind of titrate as needed. Again, for a septic patient, this is hands down my go-to medication for that. Phenylephrine is a really interesting medication as well. This is a medication, again, it's good to have in your pocket. We don't use it all that often, but I have used it certainly in the past. So this is a pure alpha agonist, right? It constricts blood vessels. And essentially it's not typically used on its own. It's used as like an additional medication. Again, if you use like epinephrine and a phenylephrine, like drips or things of that sort, you're probably constricting all those vessels on the bowels and the renals, and probably going to cause a lot of damage. You may get the pressures that you want, but it will cause a lot of damage, or can cause a lot of damage long term. And so it would not be uncommon to see somebody with like norepi drip in conjunction with a phenylephrine or with epinephrine. And so I would say those typically are kind of a backup in those septic patients. Can cause reflex bradycardia, hypotension during the bolus. And then essentially the dose is typically 0.1 to 1.5 mics per kilo per minute. And so typically if I'm using this, the go-to, or kind of where I started, was to use like a 0.5 to 1 mics per kilo per minute, just as a, like that tended to be the like the optimal range. But as far as like an ongoing, that's more of like a bolus when I was using it. But for more of like a drip or an infusion, that 0.1 to 1.5 is certainly still in the sweet spot. All right, dopamine, again, another great medication. So when do you typically use dopamine? Honestly, most of the time when you're seeing dopamine, it's actually more with cardiac type issues, and we can kind of talk through why that is. Has direct actions. It directly affects your beta more than your alpha. Again, so when you're thinking of like contractility of the heart, both in rate and squeeze, think dopamine. And so when you've got somebody with again, more of like a heart failure type of an issue, oftentimes you're going to start seeing dopamine added into that. People that have like atrial fibrillation with RVR, if you're giving them, if they're on like a cardizem drip, but their pressures won't sustain that, you can essentially start dopamine, which helps both with blood pressures and then also some of that squeeze. At higher dose, it constricts blood vessels and can lead to some tachydysrhythmias. Not a surprise, right? So you're increasing the contractility and the rate of the heart. It can lead to tachydysrhythmias. And so, again, a medication that every now and then we'll start on a peripheral line as we're like bridging to a central line, but it can lead to this decreased peripheral and renal blood flow. And again, all of these you have to be really really careful with if you're starting them off of a peripheral. Like most of these would be most definitely a central line would be the idea behind them. So if you're seeing these, every now and then we might bridge for a few minutes on dopamine while we're getting people kind of situated, but almost always we're going to have a central line in place. All right, dobutamine. So this is another fantastic medication. This one is a beta 1 greater than a beta 2, which is greater than an alpha. All right, so we'll dive back into that in a second. So the short of it is it increases cardiac output, it increases heart rate, and then it's going to decrease peripheral vascular resistance. And so again, you get squeeze of the heart, you get a bump in the rate, and then again, with this medication, I think of like heart failure, right? In heart failure, I need to essentially offload some of that pressure from their system, right? And so they're essentially fluid overloaded, and I need that pressure dissipated. And so this is kind of a beautiful medication because it decreases that peripheral vascular resistance, does some vasodilation, and essentially helps absorb some of that fluid, if you will. I guess that's the way I think about it. Mainly used in cardiogenic shock, dosing for a 0.5 to a 1 mic per kilo per minute. And you can raise it to 2 to 20 mics per kilo per minute. Again, these are going to be pretty sick patients. If you're seeing them, they're going to be in transport. So this is not a medication that I would start outside of that. In vasopressin, so again, this is a medication that I don't use, quite frankly, anymore. The dose is a 0.04 units per minute, and essentially causes vasoconstriction. In the past, this was used more with like an ACLS protocol. I honestly have used that maybe like very early in my training, but not a lot of data to support that from what I've seen in the past, and so this is not a medication that I typically use. So that we can kind of move into this a little bit. This is this is kind of maybe like a quick reference. If you wanted to screenshot this and tuck it away, it helps quite a bit, I think, as far as kind of like talking through which medication to use and why you're using it.
Yeah, I was gonna say, could you email me the image?
Yeah, and so I can, yeah, we can definitely do that. So with this one, you get just kind of going through your alpha 1s, alpha 2s, beta 1s, beta 2s, and then dopamine. Again, dopamine is, we'll talk about that again here in just a second, but your adrenaline, you're going to essentially increase that squeeze, increase the rate of your heart. It has a little bit of vasoconstriction, but again, depending on how you dose it, if it's more of like low dose, you get this bronchodilation, which is, again, for a lot of our patients with anaphylaxis, that's what we're looking for, right? And so during a code, we're actually looking for this vasoconstriction and then heart squeeze. And so kind of funny how some of these have different uses depending on how you're dosing them. Norepi or noradrenaline, with this one, you're going to get a ton of vasoconstriction. It's and you are going to get a little bit of that inotropia as well. Phenylephrine, you're going to get pretty much only vasoconstriction, which again is really beneficial for blood pressures, but is horrific on pretty much all the inner belly organs, if you will. Ephedrine, you don't see that as much as like a drip. It's not something that I typically start, but again, if you think of like even over the counter like Sudafed, things like that, you can think of it, right? Like when people take that medication, they're activating their beta 1s and they're getting that heart squeeze, and essentially they're getting like a bump in their heart rate. Dopamine. So dopamine is really interesting because it kind of affects all of these different things. The one thing that we didn't discuss specifically with it is it tends to, if you go all the way over to the far right, it does activate those dopaminergic receptors a little bit, which causes a little bit of like vasodilation in more like the bowels and the renals. And so, when you're looking at this versus like epinephrine for again, like this is a medication that we typically would use for more of like your AFib with, that's normally when I use it if I'm treating AFib with RVR and essentially my like cardizem drip is dropping their blood pressure too much. Oftentimes I'll use dopamine. I will use it every now and then on those patients that truly have more of like a rate determining issue with their heart. So for folks that are like hypotensive and have blood pressure issues or things of that sort, a lot of times they'll start dopamine drips for that. But essentially it is somewhat protective as far as like your kidneys and your bowels. So that's, again, just something good to have in your pocket and know. Dobutamine, again, you're going to see this in your, like, think of your congestive heart failure patient. And so it helps with this vasodilation. and kind of offloading, but then also helps with the squeeze. And then isoprel, we didn't talk too much about that, but actually has very similar actions, and you would use it in pretty much the exact same circumstance. Just again, a quick reference as far as which ones could be either central or peripheral. This, with epinephrine and norepi or Levophed, truly they should be central. And the reason why is because, with all of those, you're pretty much going to clamp down that peripheral vein or access, and can cause a lot of difficulty with ischemic changes depending on where that line is. And so essentially this dopamine, a lot of times, again, like we said, we kind of transition into try to stabilize folks with that sometimes when we're starting a central line, but just to be aware. All right, blood thinners, thrombolytics. Make sure we've still got time. We've got about 10 minutes or so left. I think we can get into this. So these, you're typically going to be on heparin or you're going to be on TPA. Again, this is not something that you're starting out in the field. It's something that the patient has already been started on and will be transitioning en route with. So we'll just kind of breeze through these pretty quickly, but essentially heparin inactivates several components of the coagulation cascade. Initial bolus varies between 60 to 100 units per kg. Normally, again, this depends. So normally if I'm using heparin for cardiac, I'm starting, essentially 60 units per kg for that. And then my infusion is going to be at 12. For pulmonary emboli and things of that sort, I'm typically starting 80 units per kg, and then like a 16 units per kg per hour for the infusion. And so, and then essentially they're going to titrate this. You're not going to worry about that because you're not doing it. And then it has to be administered by a pump, which should be the deal. Obviously, it can cause bleeding. Normally, it's not going to cause like spontaneous bleeding, but if there's a spot that they're already bleeding, that's where you're going to see it, right? So if they say they had a pulmonary embolus and had multiple injection sites where people were starting IVs, or let's say that they have a hemorrhoid that they didn't know about, that you didn't see or wasn't reported to you, and you start heparin. A lot of times you would see bleeding at those sites. That's where they would kind of present itself.
Is there, and I know obviously we're not adjusting heparin or anything in any way, shape, or form. Is there any reason or anything that we should look for that should say, hey, stop this and not, don't continue it and make a call kind of thing?
Yeah, the big thing is if you see pretty profound bleeding. So the biggest time where you would see an issue with this, honestly, and I don't know that you would see it in route, but you certainly could. And truly that's on people that with like rectal bleeding. So, either with this or with TPA both, the place where people typically don't know that they're bleeding, but oftentimes are, is through a GI route. And so, if you are en route and you can smell Melena, right? I mean, like you've been around enough, you would smell that, right? Like it's pungent and right.
My question would be whether it was me or the patient, but I mean, it's just.
And so, if you're starting to see significant bleeding of any sort, it's probably time to just put it on hold and make a call. So, yeah. So, can it cause bleeding? Yes. Can it cause allergic reactions? Yes. So TPA is the next one. So essentially, this one is actually the term clot busting medication, right? And so it promotes thrombolysis by converting plasminogen to plasmin and degrading fibrin into fibrinogen, right? So essentially, it's breaking down that construct or that web that blood clots are based off of. The dose depends on the use. For stroke, it's at 0.9 milligrams per kilogram IV. The max dose of 90. 10% is given by bolus over a minute, and then kind of where you'll see this is probably running the additional 90% over the next 60 minutes. And essentially it can cause bleeding and anaphylaxis. Stop if either occur, right? And so most of the time where you're going to see the bleeding again is going to be a GI source. Although you do see some people every now and then that fall and have like facial bleeding and things like that. Normally we're going to be pretty, we're going to recognize bleeding other places, right? And if it's felt to be fairly significant, that would be a contraindication to TPA to start off with. The GI bleeding tends to be where people don't realize that they've been bleeding in the past, and that tends to be kind of the spot that catches people. Insulin again is typically not something that you're going to do a lot of management, probably out in the field, but you are going to see people on drips and during transport and kind of move in from there. The big thing with insulin, it's stimulating cells to take in glucose, just like your body's insulin does, right? And so this is just kind of promoting that more and giving you another little bolus of that to drive it. DKA is typically the indication for a drip. Every now and then you'll see people on an insulin drip if they're, if their glucose is 1,000, right? And you're worried about more of like a hyperosmolar hyperglycemia. So they can be on a drip for other reasons, but almost always it's DKA. For that, they're typically going to get a bolus of like a 0.1 per kilogram. And so oftentimes here, I actually would just start like 10 units of insulin up front, and then followed by like that 0.1 unit per kilogram per hour infusion. But that's variable depending on kind of how they're responding and how you want to manage it. You got to have frequent blood glucose monitoring. So the big thing for you guys typically is going to be seeing one of these people, having them en route, them either starting to act sluggish or confused or agitated perhaps, and just making sure, I would say before these people are leaving, probably the last thing that I would do is just do like a finger check glucose before you get them on the truck, right? And I think that's probably a pretty good practice to do. If you're a longer transport, you may need to check en route, but typically if you're stable when you leave, you'll be stable before you get there. Can cause hypoglycemia, arrhythmias, hypokalemia. Again, for DKA, that's something that we're typically going to check pretty well. We typically start some potassium supplements if they're, anywhere under about 3.5 to 4. We would start some potassium because it is known to drop that. And in fact, for people with a really high potassium, we actually give them glucose to drop it down. Glucose and insulin to drop it down, because essentially it pulls insulin into the cells and it pulls that potassium into the cells too. I said that wrong, didn't I? It pulls glucose into the cells and it pulls potassium into the cells too. So apologies. Apparently when I talk for an hour, I start mixing words. Antihypertensives, we'll go through these pretty quickly as well. I know we're getting pretty close to an hour, but these are things that you'll see. So nitroglycerin, it relaxes smooth muscle and causes a decrease in blood pressure, preload and afterload. And so, again, smooth muscle. So think relaxing, like your veins and essentially kind of causing a reserve for extra fluid, anticipating that blood pressure. Drips start in between 5 to 50 mics per minute. You can go up by 10 mics per minute, up to every 3 to 5 minutes. This is a medication for like flash pulmonary edema. You can get what most people would think of would be really absurd dosing of this. We're talking, 120 to 160 mics per minute in kind of the initial phase. Normally when it would get to you, or you'd have like more of like a drip going, you're going to start backing that off. And so that's something that we would adjust really high sometimes here, and then kind of back off by the time that we would transport them. It can cause hypotension, can cause kind of like a reflex tachycardia with that, and headaches. Super short half-life, so easy on and off. If you're starting to see that low blood pressure, you can back it off. Nicardipine, you will see this probably a ton. So for your hypertensive emergencies, this is kind of the go-to medication for that. It's a calcium channel blocker, inhibits smooth muscle contraction. Start an IV typically at 5 milligrams per hour, and you can increase that up to about 15 milligrams per hour. Again, you're using it typically for blood pressure. It can cause hypotension. Be aware. So if you're seeing that, back off of this medication. That's pretty common. So, so this is nicardipine is a calcium channel blocker that typically is used for blood pressure, as opposed to diltiazem, which is a calcium channel blocker as well. But it also, so that when you're starting to look at like calcium channel blockers, again, depending on the medication, you can get more of one type of blockade versus a separate type. Diltiazem, while another calcium channel blocker, is actually used for rate control, and is pretty much always where you would see that. A loading dose typically of like 0.25 milligrams per kg over 2 minutes. You can do an additional dose of 0.35 milligrams per kg. Normally when you see this, they're going to be started on a drip. I normally start my drips at 10 milligrams per hour, and then you can max it out around 15. And so again, hypertension, headaches, you can get some bradycardia and AV blockade, but kind of the go-to medication for like an AFib with RVR. Esmolol is a beta blocker, but again, this would be typically my secondary medication for AFib with RVR. So essentially, as opposed to acting on the calcium channels, it's going to be a beta blocker. This is not a medication that I use all that often, but I typically go with that 0.25 to 0.5 mg per kg over a minute, and then start the infusion. The infusion is super low, typically at like the 0.05, and then you can increase up to like a 0.2. Is typically about where that stops for me. Hypertension, bradycardia, nausea. Again, typically with these, you're decreasing blood pressure and you're decreasing heart rate. But those are kind of the two medications for again AFib with RVR. That's about the only two places you would see it. Blood products, you can continue a blood product transfusion, but you're not going to initiate one. Again, unless you're like a flight or MICU crew. Typically, you're going to infuse either packed red blood cells, fresh frozen plasma, platelets, or cryo. You got to watch for fever, tachycardia, shortness of breath, or hives, and you're going to stop the infusion if you see any of those. So, as far as like rate of infusion and things like that, you're going to get orders from whichever facility you're picking the patient up. That's pretty much all that I have. I think that's most of the drips and medications that you guys would get or see. Ian, do you have any questions or anything that you would like addressed?
No, I think that was great. Excuse me, some of my throat, and I really appreciate that. I think it's a good opportunity to kind of get in and understand these things a little more here.
Yeah. And again, if there's questions kind of moving forward, or if there's something that's particular that you guys want more information on, let me know. I can definitely send you kind of that quick reference for the receptors. I will say in general, I pulled this out last night. So this is one of my favorite books, just with pharmacology in general. this is probably like 10 years old. You can probably buy it on eBay for like $5 or so. You don't need the most up-to-date version. This is the second edition, and it is pretty much going to go through almost all of these medications, and there will be very few updates on any of these like common medications that we would be looking at. But they give fantastic illustrations and kind of like more talking points. I'm just going to pull up a couple things here, just so you guys can kind of see. So kind of goes through some of the, I don't know if you can see that or not. I didn't put this in, but essentially like the cell receptors and kind of what's going on that direction, and you know, where different parts of the epinephrine and like norepi, dopamine, kind of where that cascade all lies. This is actually one of my favorite charts that I have seen, and this may be beneficial. I don't know if you can see that or not. But
I can't really read it, but I can see the chart. Yeah.
so it goes into a little bit more depth as far as kind of what each of those receptors does. And then, you know, the instructions, or the book actually gives a really good abbreviated synopsis. I mean, I think it's like 3 to 4 pages total, and it gives an excellent synopsis. If you're wanting more information, again, that Lippincott's Pharmacology is a fantastic book for background, and so that's been my go-to for quite a while.
I appreciate it. I feel that, you know, you should always be reading a book and always have something to reference to as far as this kind of stuff goes. So I really appreciate that.
Yeah. All right. Well, guys, that's about all that I've got today. Look forward to doing more of these. Let me know if there's any other topics or anything that you guys want to cover.
We'll do.
I already sent that quick reference that you referred to Ian.
Oh, perfect. Thank you.
Thank you so much, Kathy.
All right. And Kathy, I think we'll have you stop the recording, and we'll go from there. Thank you.